where you position
You
yourself.
cannot stay here, please.
You make it, why can't I stay here? What do you mean I cannot stay? I shouldn't do my own work. Where you position yourself is not right.
The Deputy Vice Chancellor, Academic,
It's not supposed to have something.
Deputy Vice Chancellor, Research, Innovation and Strategic Partnerships, the Registrar, University Librarian, the Provost of the College of Medicine, the Dean of Dentistry, Deans of other faculties, the postgraduate school and of students, Directors of institutes and centers, heads of departments, distinguished guests, ladies and gentlemen. The 412th in the series of the University of Ibadan Inaugural Lectures will be delivered this evening by Professor Juliana Taiwo of the Department of Periodontology and Community Dentistry on behalf of the Faculty of Dentistry. Born in Kumasi, Ghana on 26 January 1953 to Mr. Martin Theodore Dijan, a pharmacist and politician, as well as member of Parliament, MP of the First Republic in Ghana, and Mrs. Doris Jan of blessed memory, a manager who later became the proprietress, Professor Juliana Taiwo. Started her primary school at St. Francis College, Demonstration Primary School in 1959, and completed it in Osu Home Experimental Primary School, Accra, in 1965. She later attended the renowned Achimota College from 1965 till 1970 on scholarship and the Holy Child College, Cape Coast, in Ghana. Thereafter, she utilized the Ghana Yugoslavia Foreign Aid Scholarship to study for a Bachelor's of Dental Surgery degree at the University of Krelan Metoda, Skopje, Yugoslavia from 1973 till 1980. She did her housemanship between 1980 and 1981 at the Kolbu Teaching Hospital. She joined her husband in Ibadan, Nigeria in 1982 and was employed as a dental officer at the Adeoyo Specialist Hospital Yemetu by the Oyo State Hospitals Management Board. She rose through the ranks to the post of senior dental officer in 1990, from where she proceeded to King's College School of Medicine and Dentistry, London, United Kingdom, for a master's degree in dental public health, which she obtained in 1991. Professor Taiwo obtained a diploma in dental public health, DDPH, of the Royal College of Surgeons, England, the same year. In addition, she obtained several professional qualifications and diplomas, including certificate in oral epidemiology at the Intercountry Center for Oral Health for Africa, ICOH, Jos, Nigeria, in collaboration with the World Health Organization in 1989. She obtained the fellowship of the Ghana College of Physicians and Surgeons, FGCS, in 2004, and fellowship of the National Postgraduate Medical College of Nigeria, also in 2004. Professor Juliana Taiwo joined the services of this university with effect from 12th March 1992 as a lecturer grade 1 in the then Department of Preventive Dentistry, which is now known as the Department of Periodontology and Community Dentistry. She was promoted as senior lecturer with effect from 1st October 1998, reader with effect from 1st October 2006, and professor with effect from 1st October 2013. She has over 40 publications and has supervised several master's degree students and resident doctors. Within this university, Professor Juliana Taiwo has served in various capacities, including being member Curriculum Development Committee, Faculty of Dentistry from August 2009 till date, acting head, Department of Periodontology and Community Dentistry, 2009 to 2011, and from 2014 to 2016, acting sub-dean postgraduate, acting sub-dean Department of Dentistry, February 2001 and April 2002. Currently, she is head Department of Family Dentistry. Outside this institution, Professor Taiwo is an active member of the board of the Faculty of Family Dentistry, National Postgraduate Medical College of Nigeria. She is a resource person and an examiner for the Part 1 and Part 2 fellowship examinations, Faculty Secretary in 2010 and 2013, the first female faculty chairperson in family dentistry, 2014 and 2016 till date, Publicity Secretary, Medical Women Association of Nigeria, 1988, acting principal dental surgeon for the Dental Center in Dubai, 1989. President of the Nigerian division of IAA Triad, 2005, and President-elect of the International Association for Dental Research, 2004 and 2005. She has served as external examiner to the Department of Preventive Dentistry, University of Lagos, Akoka, Lagos, and the Department of Preventive Dentistry, Obafemi Awolowo University, Ilefe. Professor Taiwo is an active member of numerous learning societies. This includes the Nigerian Medical Association, NMA, the Nigerian Dental Association, NGA, the Mental and Dental Consultants of Nigeria, MTCAN, the Medical Women's Association of Nigeria, the International Association of Dental Research, and National Association of Dental Public Health. He is happily married to the Honorable Dr. Babayomi Anthony Taiwo, and the marriage is blessed with children. It's now my greatest pleasure to call on Professor Taiwo to deliver our inaugural lecture titled Nature, Disease, and Oral Health, the Conspiracy Triad of the Aging Dentition. Professor Taiwo.
The Vice Chancellor, Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research, Innovation and Strategic Partnership, the Registrar, the University Librarian, Provost of the College of Medicine, Dean of the Faculty of Dentistry, Dean of the Postgraduate School, Deans of other faculties and of students, Directors of institutes, distinguished ladies and gentlemen. Sometime in the 60s, my late father, a pharmacist, politician and cabinet-ranking member of Ghana's parliament, called his children together at the dinner table on a Sunday evening. I remembered him vividly saying that he wanted one of his children to be a professor in the medical field, another a pharmacist, and others in the financial professions. Little did I know I was going to be the one to carry the mantle of professorship. I give glory, honor, and adoration to the Almighty God, the author and finisher of our faith, for making this dream a reality. I am also grateful to the University of Ibadan, headed by the Vice Chancellor, Professor Abel Idowu Olayinka, for the honor and privilege given to me to deliver this inaugural lecture, and my Dean for nominating me. The Faculty of Dentistry, until the year 2003, was a part of the Faculty of Clinical Sciences. We have had the opportunity of presenting 8 inaugural lecturers in the following order: Professors Ilbechina, Oke, Lawonyi, Arojolu, Arotiba Fashola, Dosumu, and Dinloye. Hence, this is the 9th in series of the inaugural lectures from the Faculty of Dentistry, 3rd from the Department of Periodontology and Community Dentistry, and the 2nd from the Specialty of Dental Public Health. The first from this specialty was given by Professor Benisola Oke. In Community Dentistry Unit, the Community Dentistry Unit of the Dental Training Program was established under the leadership of Professor Benisola Oke in the year 1985 as a unit under the former Department of Preventive Dentistry. The unit maintains well-equipped primary healthcare clinics at Idikon, a semi-urban community within the Ibadan North local government area, and Igbora, a rural community in Ibarakpa Central local government area, where it provides highly subsidized, affordable dental services and from which outreach programs are carried out. The unit works in close collaboration with community health nurses, community health officers, community health extension workers, heads of schools, teachers, local and zonal inspectors of education, local government authorities, the traditional rulers, and community leaders, not forgetting the town criers. It has on occasions received international students from University of Maryland Dental School, University of Ghana Dental School, and others for rural postings. The unit has attracted research funds from World Health Organization, Diffrus Health Foundation, MacArthur Foundation, as well as donation of consumable materials from Dental Outreach for Africa and Fumi Adewale Foundation, among others. My first harrowing experience with the dental profession was in 1963 when I had toothache. I was taken to Dentist Salabi's clinic in Accra, Ghana for treatment. As I stood in the waiting room outside the surgery, I heard one scream after another. Soon it was my turn. I had a painful extraction, after which I trembled just at the mention of the word dentist or Swiss. It is obvious dentistry as a profession was not on my mind. I wanted to be a nurse. 10 years later, I went to Yugoslavia, Skopje, on scholarship with the hope of studying pharmacy so that I could take over my father's pharmaceutical company. But unfortunately, there was no faculty of pharmacy at the University Kirill and Metoda in Skopje. My admission was thus changed to dentistry. It was when I got to phantom head posting and saw artificial teeth and the drills that it dawned on me that I was studying dentistry profession. I was sorrowful because I thought I would forever be remembered for pain. Some students pursuing a career in dentistry were left-handed, and all students who were left-handed were sent to medicine except me. The dental school wanted to keep me because of my high grade point. The lecturers trained me to use my right hand. They were so professional and good that I fell in love with the profession. And since then, I have been ambidextrous, using my right hand like any right-handed dentist. My interest in dental public health was awakened in 1987 at the Dental Center, Ibadan, when one day, 6 children from the Oluyole Cheshire home, Ibadan, were brought for treatment. They had an oral infection known as necrotizing ulcerative gingivitis. This triggered my curiosity, and I decided to visit the home with a team of dental nurses to inspect the mouths of other children in the home. This stimulated my interest in research in necrotizing ulcerative gingivitis. This also signified the beginning of the team's visits to homes, schools, and underserved communities. During all these visits, the team used my resources, including my popular red Mazda car. I was then appointed the dental representative in the Statistic Committee of the Hospital Management Board, Oyo State, with a mandate to collect data and write reports on dental diseases in dental clinics in Ibadan. All these built my interest and passion for dental public health. An intern, Dr. Adewaku, who had just returned from King's College, London, was highly impressed by the team's community outreach programs. She linked me up with Professor Gilbert, the head of Department of Preventive Dentistry at King's College, London, and Ann Cushin, the coordinator of Master's Program in Dental Public Health. They eagerly accepted me for the program. Since the completion of my master's degree in dental public health, I have been actively involved in practicing this specialty. Dental public health is defined as the science and art of preventing and controlling dental diseases and promoting dental health through organized community efforts. It is that form of dental practice which serves the community as a patient rather than the individual. It is concerned with the dental health education of the public, with applied dental research, and with the administration of group dental care programs, as well as the prevention and control of dental diseases on a community basis. Mr. Vice Chancellor, sir, my contribution to knowledge is in the following areas: necrotizing ulcerative gingivitis in children, oral health prevention programs, prevention of nosocomial infections in the dental clinic, oral health of the elderly. Lately, I have focused more on oral health of the elderly, and I will therefore base the inaugural lecture on this. One day, I had the opportunity of treating an elderly friend, a 70-year-old man, who complained of tooth mobility. After examining him, I was stunned to see that all his 32 teeth were intact and he had no caries. This encouraged me to examine other elderly friends, and they had not lost any tooth or had lost 1 or 2 teeth. Literature from the developed countries revealed high prevalence of tooth loss and dentulism and dental caries in the elderly. There have been assumptions that oral health of the elderly people in Africa was similar to their counterparts in Europe, United States, and others. Mr. Vice Chancellor, sir, this conflicting observation was the basis of my research focus on the elderly in Nigeria and today's lecture titled Nature, Disease, and Oral Health, the Conspiracy Triad of the Aging Dentition. Many years ago, when I saw my father's white hair and sideburns, said that he was growing old. He answered, age is just a number. You are what you feel you are, and at the moment, I am young. The chronological age, referred to as old age, is a social construct which differs culturally and historically. The official definition of World Health Organization refers to the elderly as any woman or man who is 65 years and above. The elderly have been grouped into young, middle, and older elderly. The lecture, therefore, refers to the above age groups. WHO defines oral health as a state of being free from chronic mouth and facial pain, oral and throat cancer, oral sores, birth defects, periodontal disease, tooth decay, tooth loss, and other diseases and disorders that affect the oral cavity. Why has the elderly attracted so much attention recently? The elderly has attracted so much attention recently due to increase in their population, increase in life expectancy, change in the trend of diseases, changing trend in oral health needs of the elderly. Of recent, there has been much focus on the health of the elderly worldwide as a result of the increase in their population, transforming the population pyramid where children form a broad base to a semi-rectangular structure. Also, improved living conditions have led to an increase in life expectancy in many countries. A reduction in infectious diseases and increase in non-communicable diseases have resulted in a change in the trend of diseases. Also, comorbidity associated with oral diseases, especially periodontal disease, is common among the elderly. Improved dental technology, dental technique, and treatment modalities, as well as changes in the treatment concepts, have led to reduction in the rate of extractions and increase in preventive and restorative treatments. In developed countries, there is now an increase in the life expectancy of a tooth, with a resultant retention of more teeth in the elderly. The picture of a toothless elderly individual is fading out. The aging dentition, the role of nature. The process of aging has been long recognized. The Bible says Moses grew to a very old age, and his eyes were not dimmed, nor his strength abated. However, the fact still remains that he grew old. Therefore, the aging process of living organisms, organs, and tissues is natural and inevitable. As man advances in age, various tissues and organs undergo changes. An age change is defined as changes in the form of tissues or organs as a result of changes in their biological activities associated with reduced production of cells to replace dead cells. In the mouth, these are found in the oral epithelium, oral connective tissues, salivary glands, the tooth and tongue. There is thinning of the oral epithelium, loss of flexibility of the connective tissue, and subsequent reduction in the volume and quality of saliva produced, leading to dry mouth. All these increase the risk of oral infections involving the soft and hard tissue of the mouth. The enamel of the tooth becomes brittle and breaks easily due to ectopic calcification within the pulp fibrosis, and reduced blood flow to the pulp. Various changes take place in the tongue, including the following: atrophy of the filiform papillae at the tip of the tongue, increase in lingual varicosities on the ventral surface of the tongue, fissuring of the tongue, which encourages the trapping of food and bacteria in these fissures, leading to infection of the tongue, desquamation of the filiform papillae, resulting in geographic tongue, decline in taste sensitivity of the tongue. These changes in the tongue may encourage infection, and they have effect on food choices, which in turn lead to weight loss, malnutrition, impaired immunity, and a decline in health of the elderly. Mr. Vice Chancellor, sir, the age change in oral tissues and organs of the elderly increases their risk to oral diseases. However, it is also documented that many of the oral health problems of the elderly are mainly due to systemic diseases, pharmacotherapy, functional disability, cognitive impairment, wear and tear of the teeth, and need supporting tissues over the years rather than an age change. Health problems involving physical and medical conditions of the elderly directly or indirectly affect their oral health. Specific conditions such as mental health, severe chronic arthritis, neurological disturbances of motor functions, including stroke and Parkinson's disease, have some bearing on the ability of the elderly to maintain a reasonable standard of oral hygiene and oral health. Other systemic conditions such as metabolic disorders, immunosuppressive diseases, hematological disorders, cardiovascular disease, atherosclerosis, hormonal changes, and genetic factors modify or exaggerate the clinical presentation of oral diseases, particularly periodontal disease, through their effect on normal immune and inflammatory mechanisms. The influence of diabetes mellitus on periodontal health has long been established. Patients with undiagnosed or poorly controlled insulin-dependent and non-insulin-dependent diabetes mellitus are at risk of developing periodontal disease. Taiwo et al. In 1997 observed the highest perceived oral health needs in uncontrolled non-insulin-dependent diabetes mellitus patients, followed by uncontrolled insulin-dependent diabetes mellitus patients. They also exhibited the highest percentage with more signs of periodontal disease. Periodontal abscess in uncontrolled diabetic patients is a common presentation in the dental clinic. Pictures from the publication, Periodontal Disease in a Type 2 Diabetic Patient, a case report, was used as the cover of the International Diabetes Digest, October 1994. Polypharmacy is common among the elderly. Various drug prescriptions which the elderly are commonly placed on affect their oral health. For example, atropine causes dry mouth. Antihypertensive drugs such as nifedipine, anticonvulsant drugs such as sodium phenytoin cause tissue hyperplasia. Cyclosporin leads to gingival overgrowth. Immunosuppressive drug therapy such as steroids increase the risk of infection. Drug reaction manifests in the oral cavity as candidiasis, oral ulceration, and erythema multiforme. 81% of the elderly take drugs which have effect on their oral tissues or cause complications for dental procedures. Mr. Vice Chancellor, sir, the impact of medical conditions and their treatments on the oral health of the elderly is unequivocal. Sacrosanct to successful aging is maintaining a natural, healthy, functional dentition throughout life, including social and biological benefits such as aesthetics, comfort, and the ability to chew, taste, and speak. Indices of oral health measurement such as tooth loss, endodontalism, caries experience, periodontal health, and oral mucosal conditions demonstrated very poor oral health in the elderly in developed countries. In many countries, in many states in the United States of America, it was demonstrated that more than 20% of the elderly individuals have no teeth. Very recent data from the UK demonstrated that 20% of the elderly had no teeth at all, whilst among the remaining elderly, 43% had less than 21 standing teeth. In 2006, the attention of World Health Organization was attracted by our publication titled Pattern of Tooth Loss in an Elderly Population in Ibadan, Nigeria, which brought into focus in dental research the high life expectancy of the tooth in the Nigerian elderly and the fact that they maintained more than the WHO recommended number of teeth for the elderly into old age. These findings were included in the WHO Oral Data Bank. In our study, many of the elderly, 48%, had not lost any teeth at all, and the average mean standing teeth was 28. Remarkable is the fact that studies in developed countries implicated dental caries as the principal cause of tooth loss in the elderly. On the contrary, in our study, the principal cause of tooth loss in the elderly in Nigeria was periodontal disease, accounting for 98.7% of all teeth lost. Taiwo Omokodion, 2006. Interestingly, despite the different causes of tooth loss in the developed countries and in Nigeria, the pattern of tooth loss remained the same, demonstrating that the same teeth are more affected by both diseases. This study unequivocally reflected the findings of other studies, demonstrating increasing trend of tooth loss with increase in age. Dental caries experience in the elderly. Dental caries tooth decay is the breakdown of the hard tissues, enamel, dentine, and cementum of the erupted tooth due to the action of acid produced by caries bacteria during their metabolism. Dental caries experience refers to caries or the consequences of caries affecting the teeth. They are represented by the letters DMFT. Various epidemiological studies have demonstrated a high prevalence and incidence of caries in the geriatric population. WHO Oral Data Bank recorded a DMFT of 22.2 to 30.2 in European elderly. This means that out of 32 teeth, 22 to 30 have caries or fillings or are extracted. Taiwo et al. In 2007 examined the caries experience of the elderly in Nigeria. Our findings revealed low caries experience 14%, low caries prevalence 14%, and caries experience amongst them. The mean DMFT index was 0.46. Caries was the most prevalent component. Among 315 teeth with caries experience, 74 were decayed teeth. The molar teeth of the jaws were the teeth most affected, and caries experience was higher in females than in males. Condition of the supporting tissues of the tooth in the elderly. Periodontal disease is the inflammation of the gum and supporting tissues of the tooth, which have the function of holding it in the jawbone and supporting it during function. In a survey conducted on the elderly, Taiwo et al. Observed that only 5.2% of them had healthy gum and supporting tissues of the teeth. 94.8% were affected by various stages of periodontal disease. The majority of the elderly had gross accumulation of calculus, which is an indication of poor hygiene. A high percentage, 21.6% and 28.8% of them had teeth with shallow or deep pockets, which represent advanced stages of periodontal disease. The molar teeth were the most affected, while the incisor teeth were the least affected. Taiwo et al. In 2004 observed that periodontal disease increased with age, and the prevalence was higher in males and in the lower socioeconomic group. The gum and supporting tissues of the teeth of the Nigerian elderly suffered high morbidity. Moreover, when the mouth is divided into 6 sections, 5 out of the 6 are affected by periodontal disease. Oral mucosal lesions in the elderly. Oral mucosal lesions are superficial lesions of the lining of the oral cavity. These include the following: denture stomatitis, angular cheilitis, infection-related swelling, fissured tongue, precancerous lesions and conditions, geographic tongue, red beefing tongue, and others. Among the oral mucosal lesions, precancerous lesions have attracted much attention as they have the tendency to transform into cancer. Generally accepted prevalence of precancerous lesions around the world is 1 to 5%. Central to mucosal integrity are adequate nutrition, intact immune system, and other defense mechanisms. Glossitis, angular cheilitis, burning mouth syndrome, oral hyperpigmentation are consequences of nutritional deficiencies of vitamin B group and some antioxidants. In our study of oral mucosal lesions in the Nigerian elderly, the prevalence was 22.5%, and infection-related swelling formed the majority, 35.5% of these lesions. These swellings were mostly complications from periodontal disease, which culminated in abscess formation. Similarly, in developed countries, infection-related mucosal lesions were the most prevalent, but unlike the Nigerian elderly, these were due to fungal infection from frequent use of dentures day and night. Significant in our findings is the fact that the causes of infection in Nigerian elderly as compared to the elderly in developed countries are completely different. Denture stomatitis was of low prevalence, 3.9%, which is consistent with previous findings of minimal tooth loss and edentalousness in the elderly in Nigeria. Prevalence of oral mucosal diseases resulting from nutritional deficiencies was 14% and ranked 3rd among oral mucosal lesions. The prevalence of precancerous lesions among Nigerian elderly was very low, 2.3%, and leukoplakia was the most frequently encountered. Tooth wear in the elderly. This is loss of the hard tissues of the tooth due to factors other than tooth decay and trauma. Tooth wear is a problem affecting a significant proportion of the elderly in the world. The prevalence of tooth wear in the US elderly is 93%. Poor appearance, inadequate function, as well as hypersensitivity of the teeth are some of the complaints accompanying tooth wear. The types of tooth wear include abrasion, attrition, resorption, erosion, demastication, and abfraction. Tooth wear is caused by the following: abrasive components in the diet, abrasive dust from coal mines, cement and brick factories, parafunctional habits such as clenching or grinding of the teeth, wrong tooth brushing technique and scaling technique, using the teeth as a tool, frequent vomiting, frequent gastric reflux, consumption of acidic foods, frequent consumption of fizzy drinks. In collaboration with colleagues from the Department of Restorative Dentistry, we carried out a study in 2005 to look into tooth wear in the elderly. In our study, it was observed that although tooth wear is common, the type of tooth wear, the teeth affected more and its causes in the elderly in developed countries as compared to a developing country like Nigeria are completely different. Common in the United Kingdom is erosion due to regurgitation of gastric fluids. We observed that a high percentage, 92.8% of the elderly had tooth wear, and attrition was the commonest type of tooth wear. The molar teeth were more affected. However, only a very low percentage, 5.75% of the teeth were affected by severe tooth wear that required major restorative reconstruction. Improving the oral health of the elderly. Various efforts have been made worldwide towards improving the oral health of the people of the world, particularly the elderly. Chalmers et al. In 2015 recommended 3 major components of oral health care for the elderly: regular oral health assessment, regular oral hygiene care provision, ongoing care support, and creative treatment services, with emphasis on accessibility of these services to the elderly. Such services involve mobile dental services by oral health care workers to homes and residential care facilities. My colleagues in Community Dentistry Unit and I, just like Jason, a Greek hero, went in search of the golden fleece, have attempted through various studies and programs to reduce or minimize the oral disease burden in the elderly, as well as other members of the community in Oyo State. Many oral diseases are preventable, especially common oral diseases. Taiwo et al. In 2004 observed that majority of the elderly, 70.7% and 73.3%, physical removal of plaque through personal oral hygiene or professional cleaning will control periodontal disease. The efforts of the team in community dentistry to stem the oral burden of disease and achieve health in the community include the following: oral health education programs, oral health community outreach programs, public health surveillance of oral diseases. The team's numerous oral health education programs and screening of various targeted population groups in Oyo State over the years have yielded some fruits in improvement in knowledge of causes and prevention of caries and periodontal. Oral health community outreach programs. In an oral health community outreach program, the oral health workers go into the community to deliver oral health care through the use of mobile dental services. Mobile dental services are classified into mobile vans when the dental clinic equipment and instruments are fixed in a van, and mobile dental clinics when portable equipment and instruments are carried along in a vehicle to any suitable place where services can be delivered to the community. For example, schools, churches, tents, and other health facilities. The community dental unit of the Department of Periodontology and Community Dentistry does not have a mobile dental van. We move our mobile clinic from one place to another using available vehicles, even Keke Marua. The team embarked on community outreach programs in various places in Oyo State, including Ibaraka, Idiko, Mokola, Monia, Kishi communities, and other local government areas to deliver oral health care to the underserved communities, bringing oral health care to their doorsteps at an affordable cost. This resulted in requests from various local government authorities to establish a lower cost dental clinic in their primary healthcare clinics. A study by the team on the cost benefits of these mobile services demonstrated 70% reduction in oral healthcare costs to the patient, including transport. Alade, Arikawe, Lawal, and Taiwo. Delivery of oral health care during the outreach programs was based on the basic package of oral care, a concept developed by WHO Collaboration Center for Oral Health. It is enshrined in the philosophy of basic care for all, with emphasis on preventive, affordable, and sustainable services. The components include oral urgent treatment, traumatic restorative treatment, reducing invasive procedures and using non-invasive procedures and resin-based materials. Affordable fluoride toothpaste is also included. Fluoride in toothpaste has contributed immensely to the prevention of caries worldwide. This last component of this concept was quite challenging to the team. Taiwo et al. In 2004 observed that many of the elderly in Nigeria, especially in the rural areas, use chewing sticks to clean their teeth as toothpaste was not affordable to them. If we must achieve good oral cleaning habits in the elderly and sustainability of the AFT component, methods used must be incorporated into their existing oral cleaning behavior. The above questions led to a study conducted to investigate the fluoride content of commonly used chewing sticks in Nigeria. This study established the presence of various concentrations of fluoride in the commonly used chewing sticks in Nigeria, 54 parts per million to 1,845 parts per million. Mr. Vice Chancellor, sir, for the first time, Taiwo et al. In 2012 converted the concentration of fluoride in chewing sticks into parts per million, making it comparable in dental literature to fluoride in other topical fluoride products. For the first time, it was also established in this study that one of the chewing sticks, Xanthoxyloides, known in Yoruba as Orienta, contains more than enough fluoride, 1,845 ppm. A little more than fluoride in toothpaste, but within the safety limit of 450 parts per million to 2,250 parts per million, recommended by Bashen et al. In 2010 for topical fluoride application. Xanthoxyloides, if properly and regularly used, is likely to confer maximum anti-caries effect, and its use should be encouraged among chewing stick users, particularly rural dwellers and the elderly. This enthused the authors to further look into the retention of fluoride in saliva after the use of chewing sticks as compared to its retention in saliva after the use of a non-herbal fluoride toothpaste. Mr. Vice Chancellor, sir, the novel revelation was stunning. For the first time, the team was able to show that natural fluoride in Xanthoxyloides was retained in the saliva longer than fluoride in non-herbal fluoride toothpaste. Fluoride, therefore, will be easily accessible to the elderly in this environment with very little effort and at a very low cost, affordable to the elderly. I had to ask one of my colleagues, why are we traveling to Sokoto to look for fluoride when public health surveillance is defined as a continuous systematic collection, analysis, interpretation, and dissemination of data on a health-related event, the purpose for which include the following: use in the control of diseases to reduce morbidity and mortality, improving health, measure trends of diseases, guide planning, implementation and evaluation of health programs, identify population at risk, and other various public health activities. Efforts in the developed countries have led to the development of a non-clinical surveillance methods using oral disease surveillance questionnaire, which can be included in medical surveillance questionnaire. A good example is the periodontal disease surveillance questionnaire. Such surveillance instrument has not gained attention in Nigeria, To encourage surveillance alongside medical surveillance, our team in 2017 conducted a study to determine the validity of the periodontal disease surveillance questionnaire in a Nigerian population. This study demonstrated low validity of this questionnaire with receiver operating characteristic curve value of 0.6. The low validity observed was due to many of the questions in the questionnaire not being consistent with oral health behavior of Nigerian people. Another study which looked at the validity of individual questionnaires in this questionnaire demonstrated better validity of questions which reflect more advanced stages of chronic periodontal disease, such as mobility and pocketing. Various training workshops were conducted for community health extension workers and teachers with the aim of training them to identify oral diseases, give dental first aid, and refer them to the dental clinic for further treatment. A book titled Handbook of Oral Health Care for School Teachers and Community Health Workers was written by the team for non-dental medical personnel to complement the above training workshop. Taiwo, 2012. In our study of the impact of the training workshop on community health extension workers in Ibadan, there was great improvement in their knowledge of oral diseases and treatment options, with means called for pre and post training of 31.7 and 48.2. Did we find the golden fleece? Mr. Vice Chancellor, we are still searching. The world is still searching. The golden fleece is in your hands, in my hands, and in everybody's hands. Changing the lifestyle of behavioral practices and making oral health care accessible and affordable to all will bring us close to the end of this search. Mr. Vice Chancellor, sir, in conclusion, in discussing the triad of the aging dentition, I have explored the effect of the age change of oral tissues and medical diseases on oral health of the elderly. I have also unfolded the oral health status of Nigerian elderly and elucidated the efforts of the community dentistry team to improve the oral health of various underserved communities in Oyo State, including the elderly. Mr. Vice Chancellor, sir, highlights from our studies on the elderly, which emerge as contributions to knowledge and health and has its implication in oral health planning, include the following. In comparison with the elderly in developed countries, the life expectancy of the tooth in the elderly Nigerian is very high. The average Nigerian elderly maintains more than the WHO recommended minimum number of teeth for the elderly into old age, and the dentalousness is extremely low. Unlike the elderly in developed countries, the main cause of tooth loss in the elderly is periodontal disease. Despite the different causes of tooth loss in both developed countries and Nigeria, the pattern of tooth loss as well as tooth retention remain the same. The caries experience in the Nigerian elderly is very low, contrary to the findings in developed countries, with the decayed component dominating, which in the eyes of a dental public health officer represents signs of unmet need. These studies highlight the differences in the types and patterns of tooth wear in Nigeria and the elderly as compared to the elderly in developed countries, with attrition emerging as the commonest tooth wear among them, and it emphasized that very few teeth have very severe tooth wear that will require very advanced, expensive and reconstructive restorations. Of great concern is the high prevalence of periodontal disease in the elderly, a disease now established as a precursor for many non-communicable medical conditions. Also, despite the high prevalence, majority of the elderly suffer from the early stages of this disease, which is reversible. Consistent good oral hygiene procedures A non-surgical periodontal treatment intervention will drastically reduce this prevalence. Just like the developed countries, infection was the most prominent oral mucosal issue. In developed countries, fungi was the cause of infection. However, in the Nigerian elderly, infection-related swelling resulting from complications of periodontal disease was the main cause of infection. Of much concern are the oral diseases resulting from nutritional deficiencies, which rank third among oral mucosal issues. Adequate fluoride in the chewing stick, Xanthosxylum xanthoxyloides, and its long retention in saliva has good and great dental public health implications for oral health. Also, its use in community oral health programs for prevention of caries in rural areas in developing countries is highly recommended. Surveillance of oral diseases using cheaper, non-clinical, and non-invasive alternative methods will be an added advantage towards the improvement of oral health. The step taken by our team to validate the periodontal disease surveillance questionnaire, which demonstrated low validity, will encourage further efforts to develop oral health surveillance questionnaire, which can be used in this environment. This will facilitate regular surveillance of oral diseases in the country. Our studies drew attention of the world to the different oral health conditions and the different causes of oral diseases in the Nigerian elderly as compared to the elderly in the developed world. It is for this significant fact that the World Health Organization included the findings of our publication, The Pattern of Tooth Loss in the Elderly Population in Ibadan, Nigeria, in its oral data bank. Recommendations. Mr. Vice Chancellor, sir, I am using this opportunity to congratulate you on the team of dentists you have in the dental faculty, who have demonstrated the determination, strong will, tenacity, and knowledge, and team spirit, which have led to a successful faculty. Sir, our community dentistry team has been renting buses for our outreach programs because we do not want the dream of extending oral health services to the underserved communities to die. We need a mobile dental van. A community dentistry unit is not complete without a mobile dental van. All dental schools abroad have it. We have prepared a proposal for a cheaper mobile dental van assembled locally, which can be of use to the Nigerian government. Mr. Vice Chancellor, sir, it is said that mobile dental vans improve the visibility of dental schools in the community. Whenever we go out into the community, we hear the people saying, "Àwọn dókítà wá láti UCH àti UI ti dé o." To the government of Nigeria, there is need to establish a more robust oral healthcare system with a strong primary oral healthcare component incorporated into primary healthcare clinics. Also, a well-established oral health surveillance system is required, which will enable us to follow the trend of oral diseases and improve the oral health of Nigerians. Even when we have primary oral health care clinics, there is need to reach out to the hard-to-reach populations in the remote areas with difficult terrains. The mobile dental van proposed above will be just the right vehicle to tour these areas. There is need for the government to focus on improving the oral health of the populace, especially the fast-growing population of the elderly. To the audience, dentism, tooth loss, and periodontal disease are not synonymous with aging. oral diseases, especially periodontal disease, are very pleasant, and by the time you notice them, they would have advanced beyond your expectation. The 6 monthly dental checkup in the dental clinic is imperative. Acknowledgement. I return all glory, honor, and adoration to the omnipotent God for making today possible. I am very grateful to the University of Ibadan, the premier university, and the University College Hospital for affording me the opportunity to serve, to develop my career, and to contribute to knowledge. I thank the former and present Chief Medical Directors, Professor Elesomi, Professor Tope Alonge, as well as the Chairman Medical Advisory Committee of University College Hospital, UCH Ibadan, Professor Otebayo Afolabi Akimoladu, for believing in me and supporting the Department of Family Dentistry. I appreciate the National Postgraduate Medical College of Nigeria for giving me the opportunity to serve. I am immensely grateful to the traditional rulers, especially the Iba of Kishi. My Kishi people, I thank you all. Community leaders, chiefs, local government chairmen, and the elderly from various local government areas for their cooperation and participation in the oral health care programs. I will forever be grateful to my father, Mr. Martin Kyodojan, of blessed memory. Despite his busy schedule in business and politics, he dedicated quality time to personally prepare my siblings and I for the common entrance examinations and scholarship interviews to gain admission into the premier school in Ghana, Achimota College. Papa, I thank the Lord that your efforts have not been in vain. How can I forget my mother, late Mrs. Doris Jan, who imparted me with the time-tested values of diligence, hard work, and honesty. Mama, I still cherish these values till today. On my return from King's College, London, my husband and I sought the advice of his Loyola College senior, Dr. Peter Boom, then a senior staff at the College of Medicine, University of Ibadan. After looking at my credentials, he advised me to go into academics. He took us to the Dean, Faculty of Clinical Science and Dentistry, and after all necessary formalities, I was offered an appointment as a lecturer 1. Dr. Peter Boom, Professor Ijadola, I sincerely appreciate you. I cannot forget to mention Drs. Oguyinka and Kolude, Professors Arotiba, Fashola, Denloye, who made me feel welcomed when I started work in College of Medicine. I acknowledge all my teachers and mentors, especially Professor A. Okuniyi and Professor Ijaduola, who introduced me to the act of publication. Professor H.I. Ajagbe, Dr. B.O. Abiose, Professor D.O. Lawonyi, Dr. Sofori J.B. Aduayi. I appreciate all of you. My gratitude goes to Professor Beni Soloke, a true leader in dental public health. Whenever there is a project, her usual expression is, "We have a project." Nothing is ever hers alone, even when she is the originator of the project. This selfless attitude and respect for everybody's contribution created a strong bond among all of us in the unit and has been the sustaining and surviving factors of all projects in community dentistry unit, with the IDICOM project still surviving after approximately 30 years. I acknowledge my fathers in dental public health, Professor Kizo, Professor S.O. Jeboda, Professor E.O. Ogubondede, incoming Vice Chancellor of Obafemi Awolowo University, I acknowledge my fathers in family dentistry, Dr. Taiwo of blessed memory, Ekesebikwe Akilaja Obisheson Motayo of blessed memory, my able secretary, Dr. Adetoye and Dr. J. Olunuga. I thank you all for believing in me and for your robust support. I thank my head of department, Professor Arowo Jolu, for her support. I am grateful to my colleagues from University College Hospital, the Medical and Dental Consultants Association, Ibadan, for their brotherly and sisterly love. I give tribute to my colleagues in Community Dentistry Unit, Dr. Sibiyemi Lawal Osudedeke Alade, all resident doctors in the unit, house officers, and public health nurses. This achievement would have been impossible without your hard work, dedication, tenacity, and team spirit. I acknowledge all lecturers in the dental faculty, especially Drs. Popola Adisa Ibiyemi Temisare Lawal, for assisting me in the Department of Family Dentistry. I am grateful to everyone who in one way or another assisted in the preparation for the inaugural lecture. Members of the inaugural lecture committee led by Dr. M. Ajayi, I appreciate you all. I acknowledge the dental family, resident doctors, house officers, dental therapists, dental technologists, dental surgery technicians, administrative staff, especially Mrs. Kunle Ajabe and Mrs. Pratt Oyelaki Oladoyibo, Mr. Edwin Isaac of St. Catherine's College. I thank you. Special thanks to my wonderful siblings, my elder brother and former director of Bank of Ghana, Mr. Philip Jan of blessed memory. My younger brother, Mr. Tony Jan, the pillar that holds all the family businesses together in Ghana. My elder sister, Roslyn, my younger sisters, Florence and Theodora, all in the USA. I thank you all for maintaining the strong bond among us. I thank my extended family, the Hutchison, Grant and Jan dynasty, for their constant support. I consider myself blessed to have the best in-laws anyone can hope for in the Taiwo dynasty. The patriarch of our family, Chief Olakoju Taiwo, a retired permanent secretary and former commissioner in the Civil Service Commission of Osun State. His amiable wife and matriarch of our family, Chief Mrs. Adenile Taiwo, all of them are present here. I appreciate you all for your love. I appreciate the love and support of the following: Sir Engineer Busayo and Lady Florence Taiwo, Professor Baba Femi Taiwo and his wife Dr. Tolulope Taiwo, Dr. Chief H.T.O. Ladapo and his wife Chief Mrs. Nike Ladapo, my husband's political leader and our family friend Honorable Chief Oladoshi Oladipo and his amiable wife Mrs. Lodi Oladipo. All of them are present here. Then also the presiding Bishop of Victory International Church, Bishop T.V. Adelaku, his wife, Pastor Dolapo Adelaku, and the entire congregation of Victory International Church. Well done. I thank you all for your love. I appreciate the cooperation and support of our children during this journey. Dr. now Mr. Oluwatosin and his wife Cynthia Taiwo in the UK, Dr. Tolulope Taiwo, a consultant radiation and clinical oncologist, and Mr. Temitayo Taiwo, coordinator St. Catherine's Schools. I bless God for making you all children of joy and delight. Finally, to my husband. Finally, husband, friend, and confidant of more than 40 years. The Honorable Dr. Babayomi Aduramigba Taiwo. You are indeed Aduramigba. I bless the day we met in 1973, and I thank God for making you my motivator and greatest source of inspiration and encouragement. I love you with all my heart, darling. I thank you and this incredible audience for your kind attention. God bless you all.